This is Precision, Perspectives on Children's Surgery from Anne and Robert H. Lurie Children's Hospital of Chicago. I'm your host, Erin Spain. On this podcast, we introduce you to surgeons at one of the country's most renowned children's hospitals to find out how they're transforming pediatric medicine. Today, we're talking with the leader of a new program at Lurie Children's that will help transform the lives of children born with some of the most complex heart and lung conditions. Dr. Elisabeth Martin was named the director of the Pulmonary Artery Reconstruction Program and Surgical Outcomes Research. She has joined the team of experts within Lurie Children's Heart Center to advance care for children with complex congenital heart disease and to continue developing innovative surgical approaches that can transform these young patients' lives. We welcome her to the show to talk about her areas of expertise and what's in store for patients seeking care through her new program. Welcome to the show, Dr. Martin.
Thank you for having me.
So tell us a little bit about your background, where you grew up, where you came from, and what brought you here to Lurie Children's.
I'm French Canadian. I was born speaking French only, and so I did most of my training actually in Quebec, medical school in Montreal, cardiac surgery residency in Quebec City. And then after completing medical school and cardiac surgery residency, I wanted to complete congenital training. So I moved to Toronto, spent some time in Boston as well. And then from Toronto, I made it all the way to California. And then I spent a little bit more than 7 years actually in California at Stanford Children's Hospital.
Let's start with the name of this new program at Lurie Children's. What exactly is pulmonary artery reconstruction, and how did this surgical procedure come to be something that you are an expert in?
It's exactly the reason why I decided to go to California, actually, in the first place. I wanted to learn something that's quite cutting edge and learn from the pioneer of the procedure, essentially with Dr. Frank Hanley, who, through approximately 30 years of experience, he took care of, I think, the most challenging or the most extreme trilogy of fellow patients with different types of procedure to eventually complete a full cardiac surgery or full repair, essentially, so the babies would not be blue anymore.
What do you mean when you're talking about these babies are blue?
Very good question. So at baseline, when you have tetralogy of fellow, pulmonary atresia and collaterals, the heart that has, the 4 chambers, you have a big hole in the heart, and then the vessel feeding the lungs, instead of really coming from the heart, then frequently they're going to come from everywhere in the body. And so because there's a big hole in the heart, because the lungs are not seeing a smooth blood flow or smooth flow distribution to the lungs, then those babies actually will not have an oxygen saturation of 100. They can have a saturation ideally in the 80s, but sometimes it could be saturation in the 70s or in the 60s. Frequently, we'll see patients that will require oxygen as well over the following months. And really, there's no other treatment that will fix those babies except surgery. So oxygen is to temporize.
By temporize, you mean to manage the symptoms temporarily, knowing that a real solution, the surgery, is coming later?
Yeah, sometimes they get a blood transfusion if they have some anemia to temporize again. If patients are really, really blue, or if they have some airway abnormality, they can have a CPAP at night, or even sometimes a tracheostomy. So all those strategies really are just to buy time. The only way to fix the blueness is to go for surgery. So really to recruit all those vessels together, close this hole in the heart with a patch, because it's really a big hole. So you cannot just bring the tissue together. So you really need to recreate a portion of the wall. So you need a patch that you sew in place. And then also because they didn't have a pulmonary valve, then you need to place a pulmonary valve. The surgical intervention is really the best way to move forward. So you can have then after that a heart that's pumping as efficient as possible. So blue blood one way, red blood the other way, not be blue anymore, and just kind of keep on moving and growing and doing all the normal baby things. And it became, I think, one of my favorite procedure, essentially, to take care of those patients. And I think what's also very important is not many hospitals or many centers are actually tackling this type of pathology. I think it's given the complexity. It's overall quite rare. And so you need to build this expertise as well. So it becomes part of almost your regular type of practice. So you can build the expertise as well. So you need a full team of people that are very interested into caring for those patients.
What's that like for family members to see their baby? Their color has changed. They're improving.
It's usually quite shocking because there's a lot of preoperative education. And so they learn to measure saturation at home. How is it if they are on oxygen? a little bit of oxygen, even more so. So parents are really used to, oh, now it must be in the 80s. So now it must be in the 70s. The numbers, like just looking at, the color, sometimes the lips. And then when you tell them after surgery that now the saturation is 100 and it's, all pink, it's actually very rewarding. The parents are like, oh my God. It's like, it's a first thing that they see, right? It's really the color of their baby. And so it's a good feeling for the surgeon to say that.
With the pulmonary artery reconstruction, this really gives kids another chance at life that they wouldn't have had without this procedure. Can you share some examples or stories about this?
Have a few stories
I bet.
for sure. I think even though it was quite a rare procedure, across the country, I would personally do approximately one of those procedures a week. And so that's one of the reasons why, I build the expertise is by performing this surgery at regular basis. And so I do have a few stories. This teenager, I remember, showed up with heart failure. So the heart was failing because there were obstruction in the pulmonary bed, and the heart had been pumping for many years against obstructed outflow. And so the heart was becoming weaker and weaker, but also the vessel feeding the lungs had been damaged from previous surgery, previous catheterization and stents. And so the option were, is it a heart-lung transplant, or is there a type of repair that we can attempt to preserve the heart from failing further? And this repair could actually tackle the pulmonary arteries in a way where, the blood flow would be as distributed equally for the right lung and the left lung. And so I thought I could do a repair. And so I did a repair, trying to avoid this heart-lung transplant, which for children and teenagers, or I guess just in general, it's not a great option if you can avoid the transplant. And so the surgery was successful, and the patient actually, went back to school, went to concerts, saw them a year and a half after surgery and was doing great. The heart was pumping great. The lungs had recovered completely. And I don't think this patient will need heart-lung transplant ever. And so I think these surgeries are complex, but it works. It can avoid transplantations, and just have to have the perfect team, or a team that's really interested into, building this type of expertise, but it's absolutely doable.
One of the other procedures within your expertise is the unifocalization reconstruction procedure, which saves some children from having to undergo a series of 3 surgeries. Tell me about this procedure.
The history started by doing the surgery in 3 steps. So exactly as you mentioned, so first you would start by reconstructing the right lung, and then you would complete with the left lung as a second step. And then the third step would be from a third incision from the front, where you would then bring the left reconstruction, the right reconstruction, and then complete the repair from the front. And so those patients would need to go over 3 surgeries, 3 sedations, 3 recovery periods to hopefully get to a result where you could fix the heart completely, close the big hole in the heart, and not be blue anymore. What could happen with those intermediate steps, though, is, patients would become sick. The lung that had not been repaired would become more sick over time. And so it was actually quite challenging. I actually had never done this 3-step approach, because really, when the way I learn it is everything in one sitting in 75% of the cases, where you actually just go from the front to the breastbone, and then you complete the entire repair, the right lung, the left lung, and fix the heart and the big hole in the heart as well in one surgery. It's a lot of work. So those are long procedures for sure. I would say could be from 8 to 20 hours, depending on the extent of the repair. But the end goal, however, is you fix everything in one surgery. And so I think it avoids having bad lungs over time if you go through, the 3-step approach. It avoids becoming sicker in the meantime as well. But it's a bigger step in one sitting, but that's also something that is working and is successful.
You mentioned that the surgeries that you perform are among the most technically demanding in pediatric cardiac surgery. How do you approach each case? How do you get yourself ready for these very intense surgical situations?
Actually, many families will ask that question. It's like, how can you actually do a surgery and be focused for 10, 12, 16, 20 hours? Well, personally, I started with cases that were on the less complex end of the spectrum to kind of feel more comfortable with the complexity of the repair, the 3-dimension reconstruction, how to also recruit some of those vessels that are sometimes 1.5 to 2 millimeters. So those small vessels have to be, very careful with tissue handling. And so even when I started a few years ago, the cases were well calculated. And so I would feel comfortable, moving forward with this type of repair. And then as because I got more comfortable and more curious as well. I pushed the limit a little bit, for sure. Instead of, an outcome such as a heart-lung transplant for a young patient or a young teenager, I would definitely feel more comfortable offering a more complex repair. And it's like, how do you grow a stamina for someone who's running marathon? You always start with shorter runs and then 10K and then half marathon and then marathon and then Ironman. And so that's kind of how I explain the analogy to families when I say it's going to be a long surgery, that it's 20 hours and it is what it is. It's not the first time, and I've trained. I think it's really training. Similarly with the team that's with me. It's not only me that's in the operating room. There's a full team that's there.
You mentioned the team, and Lurie Children's is home to one of the nation's top pediatric heart centers. How does this new program build on that foundation and expand what's possible for the young patients coming to the heart center at Lurie Children's?
I joined the team that's very excited with innovation and building something new and, adding to their really well-established expertise. There's a very strong team, for instance, the cardiologist, the anesthesiologist, the perfusionist that helped me for, the heart-lung machine, the ear, nose, and throat, ENT surgeons that also very important to this program, the ICU, the pre-op care, the nurses. And so I think it's a multidisciplinary approach. There's already very strong foundation with all those teams. And that's what I was able to even witness myself when I was talking about the program, talking about my vision of how I think we should be incorporating those patients into, the Lurie Children family. And everybody was already very excited, very on board, not scared of adding something to their, to their toolbox as well and building things. I think it complements what Lurie is already doing.
You mentioned the word innovation. What role does innovation and research play in your work? And how will any data that you're able to draw from your procedures, how will that help guide the future of this program?
I think surgical innovation at baseline is very difficult. It's always how to balance the risk of something new to the status quo that you already know what should be the expected outcome. And so there's always a challenge when you bring something new, even though, it's been established in other parts of the country. But again, it's not really well known. Actually, nowhere is doing this really. And so I think it brings some challenge to explain what it needs to be done to accomplish the same results. And so I think surgical innovation is great though. I'm very excited about it, but it's for sure, it brings some challenges as well from an organizational standpoint, making sure that everybody's aligned of what needs to be done.
What about the research component?
It's definitely something I am working on the side from the basic component of why are there some patients that are born without pulmonary arteries? Why does that even happen? Why are you part of that extreme spectrum of tetralogy of Fallot? I think there's a lot of unknown. Those vessels are not what they should be from a genetic level, from a molecular level. So there's a lot of unknown for that. They don't always behave the same way in terms of the size, the growth, the obstruction that will happen over time. So there's some mechanism for sure that we have no idea. And so that's something that it would be great to try to explore more on the side. And, there are also the other syndromes such as Alagille or Williams syndrome or elastin arteriopathy. So there are also other vessel anomalies that become very thickened. Now we're also pushing the limit more in terms of how much we can help those patients in terms of their pulmonary arteries and why some of them are so severe. And that's something that we don't know yet. And so I think we are just starting to work on that.
You have expertise in neonatal surgery. You mentioned teenagers. You even follow patients with adult congenital heart disease and see them as well. Tell me about this spectrum of patients and the expertise that you have with these different ages of patients.
I think I was very lucky since the beginning. I was really able to work from, neonate, small babies, preemie, up to the grown-ups. And I think it's one of the fascinating part of pediatric and congenital heart surgery is you can really actually follow patients from birth until later on. You get to learn as well from an adult congenital heart disease standpoint. There's still follow-ups that we're learning with patients that's not been well established yet. And so there's a lot of unknown even for those patients that come, in their 30s or 40s with their own previous surgical history, with multiple previous surgeries. And then you see like, oh, what's happening now? And so that's also fascinating. And then I think the neonatal surgery work is also the intricate small baby, small heart that I really like. So I think, and then I also did some transplant and mechanical support and mechanical heart, all the devices, which is also part of, I think, what a pediatric heart surgeon should be comfortable is eventually sometimes, the hearts are not progressing well. So you have to go for a transplant route. So I think I was lucky to cover all the spectrum, the entire spectrum of the practice, really.
What made you want to come here to Lurie Children's to bring these skills that you've acquired over the past decade or more and establish this program at Lurie Children's?
I felt like in the Midwest, there's a large population of patients. I remember also seeing patients coming from everywhere and operating on patients from Lurie Children, actually. And I think from a strategy standpoint, a teamwork standpoint, the team is very enthusiastic about helping me also do this. And the challenge of the unknown as well. I was really excited to be learning to work with new people, knowing their expertise, their willingness to support me and collaborate and help build this. I think it's all this combination of all those elements that made it very, very exciting to come here.
For patients and families, they do find their way to your program. What do you want them to know about the care that they're going to receive?
It's really a comprehensive team that will be caring for their children, even before we talk about surgery. So it involves like, okay, so what's the problem with the heart? What do we do about it? What's the timeline about it? So there are a lot of people that are even involved in those discussions before we talk about scheduling an OR date. I think it's very important to educate families, to let them know what needs to be done, what's the timeline. And then I think it's very important also to, when we're getting closer to surgery, to explain what's going to happen the day of the surgery, what's the expectation being in the hospital, how long do you stay in the hospital, and then the lifetime expectations. Like I said, those patients are born without a pulmonary valve, and that's a guaranteed reintervention because the babies are going to keep growing and the pulmonary valve is not going to grow. And so you need to be prepared to come for future cardiology appointment. You're going to have catheterization as well, eventually a future surgery. And so I think the care is not only surgery. It starts before, of course, surgery and the post-op, but it also follows after. And I think the team here really is doing that super well. Hopefully that can bring some peace to that.
It's a partnership, like you said, for many years that you'll be together with these families and patients and caring for their child. So it's kind of the beginning of a relationship, really, when they come here to Lurie Children's.
The analogy of going to the dentist. You have to keep going to the dentist, even if things are going well. And it's the same thing for cardiology, making sure that the heart is healing well, making sure that there's no surprises that happens over time and all of that. And so you need to have, it's almost like a membership to cardiology, essentially. Yep.
Just become part of the community.
Yes.
Yes.
Absolutely.
Well, thank you so much, Dr. Elisabeth Martin, for all of this information today. This is very valuable to families who are curious about this program and have found their way to Lurie Children's. So thank you so much for all of your insight today.
Thank you for having me. I appreciate it. Thank you.
For more information, including how to make a referral or an appointment, visit luriechildrens.org.